So the next section are the immune targeting drugs, and we've already talked about the first group of drugs in this class. Sorry, I went too fast. The steroids, and so you can subdivide the progression of asthma, so to speak, into kind of an early phase versus a late phase response. But at the end of the day, all of these processes, or both of these processes, are basically kind of exacerbated or put forth by the immune system. You can see all the different immune cell players here, and I'm sure Dr. Richards is going to go into much more detail about the different subsets of immune cells that are responsible for kind of this asthma progression. But probably the most potent immunosuppressive drug that's out there are your corticosteroids, or often called your glucocorticoids. And we had talked about these back in Foundations of Medicine. I just wanted to remind you. We've got both inhaled formulations, which are listed here, as well as oral formulations, basically prednisone and methylprednisone or methylprednisolone. Understand that from the biochemical standpoint, all the corticosteroids have 21 carbon molecules, and they can be subdivided based on their physiologic effects. And so your glucocorticoids are, of course, corticosteroids based on their carbon number, but they alter glucose, they change physiology, and they are immunosuppressive. And so these are all of your glucocorticoids. In contrast, your mineralocorticoids, also 21 carbons, primarily affect mineral homeostasis, basically sodium, as well as some others. And those are going to be talked about a little bit later when we do the kidney portion of the curriculum. Okay, and so we said earlier that these corticosteroids are, really potent immunosuppressive drugs, and that's because they operate essentially at the genomic level. And basically, when you give an immunosuppressant type molecule like a corticosteroid, they basically inhibit the production of certain pro-inflammatory proteins and enzymes and receptors and so forth. And the last count that I looked at was up to 20 to 30 genes that produced pro-inflammatory proteins, cytokines, chemokines, and so forth were reduced in expression by steroid administration. All right, and so these are really potent drugs. Understand, we talk about immunosuppressive, we can kind of put them into two baskets. Remember we had talked about, or perhaps that COX inhibitors are your non-steroidal anti-inflammatory drugs. So the contrasting group of drugs are the steroidal anti-inflammatory drugs, which are, of course, your corticosteroids. And so it's just kind of a tidbit of little pharmacology trivia. The steroids that are administered are going to block the late phase reaction that's in that response to those allergens that really are the causative agent in reducing airway flow. Okay, and they're also going to inhibit the ability of these inflammatory cells to become activated, and also in order to do that they need to migrate. And so all 20 or 30 of those genes that are inhibited by the steroid at the genomic level, this is basically the physiologic outcome to that. Okay, and I said earlier, these are the most potent ones that are out there. When we talk about ICS, we're referring to the inhaled corticosteroids, which were on the previous two slides. And these are used for kind of the long-term control of asthma. You'll often see short courses of oral systemic steroids like prednisone. And that's really to kind of get a really strong hold of the disease. So you've got kind of a really bad exacerbation of asthma. You may think about putting a patient on a short course of the oral steroid packet like prednisone. Maybe some of you have taken the Medrol dose pack for a variety of reasons. That'd be an example of an oral systemic corticosteroid. And so you could use it to kind of gain a really strong control of this persistent severe asthma. And then also, of course, you'll be also implementing the beta agonist and possibly even an inhaled corticosteroid as well. But that might be a little bit of counterintuitive in terms of the amount of steroid the patient's exposed to. In terms of the major side effects, aside from inhibiting 25 or 30 genes that produce inflammation, hoarseness is one of the major kind of reported side effects, because there's definitely a local effect on these inhaled corticosteroids on the vocal cords. The other thing is oral thrush, which is a candidiasis type of infection. It's relatively easy to prevent. Just tell the patient to gargle with water and then spit after the steroid administration is inhaled. And then if it does manifest itself, it's easy to treat. You can use some of the topical antifungal agents, which are listed there, or you can use a systemic oral antifungal agent, such as fluconazole, and that'll clear this thrush infection up relatively quickly. Because there are, side effects to both oral and systemic administration, as well as hormonal effects as well, we can use this particular formulation called cyclosinide, and this is kind of cool. This is an orally administered pro-corticosteroid, and so biologically this drug does nothing until it actually goes through the biotransformation pathway, and that pathway actually occurs in the ciliated epithelium of the bronchi. And so this drug does nothing until it gets to the anatomical site of where it's supposed to be working. And then there it gets biotransformed and activated. And so you get a deposition of active drug into the anatomical site where you need it most, and it basically has no effect in the earlier sites anatomically as it goes down the GI hatch, so to speak. All right. And so the implications for oral versus inhaled therapy are pretty obvious. And so here, here's your oral dose, which is, this is a green tablet. It gets biotransformed or metabolized through the liver. So here you're thinking of that LADME process, of course. And then it becomes activated. And here you see systemic, absorption and distribution throughout the body. But then, because a lot of these drugs are specific to a given receptor, and that receptor primarily resides in the bronchial compartment, you have to wait for this active metabolite to go through the entire circulatory system and then come into contact with those specific receptors within the bronchial compartment. And then, of course, that's where the physiological effect occurs. After that effect occurs, the remaining drug, or the drug that doesn't get bound, gets excreted. Okay. Excuse me. And so this is kind of standard pharmacodynamic and pharmacokinetic effects upon an oral dose. And so this is, kind of that age-old question: how does a drug that you take, by mouth, eventually get into the liver, get into the lungs, and it has to go through the entire bloodstream to do so? And that's that LADME process. So this is in contrast to the inhaled dose, which puts a aerosol version of the drug and it passes into the bronchial epithelium quite readily. And there, the drug is either activated in the case of cyclosinide, or it's already active in the case of all the other drugs that are inhaled. And that has the primary effect of basically addressing this bronchial compartment, because it gets delivered to that bronchial compartment quite readily. And of course, the excretion pathways could be through feces, bile, as well as exhalation. Okay. And so just to kind of quickly compare and contrast some of our early pharmacodynamic, pharmacokinetic principles, here's your IV administration, where you have relatively short absorption, okay, and you see a really high plasma concentration relatively quickly after administration. And this is in contrast to the oral dose, where you see this lag phase right here. And this is that process of that liberation, absorption, distribution phase right here. So you don't see the peak plasma concentration until much later. So this would indicate that the IV drug works a lot faster than the oral drug, and that's why we had said back when we had started this curriculum that patients in the emergency room are often given IVs, because basically the drug works a lot faster. So you get a stronger control of the disease. All right. So what does this mean for inhaled drugs? Well, inhaled drugs kind of have a similar distribution curve, kind of like the IV drugs. These inhaled drugs reach, their peak plasma concentration, or their peak concentration within the lungs, relatively quickly. Okay, and so maybe plasma concentration, maybe we couldn't call it plasma concentration, but maybe we'll call it lung concentration. That's a little bit better. The inhaled drugs reach their peak lung concentration at a much quicker time frame than some of the oral agents. And so that gives us kind of some unique properties of inhaled drugs. And so we see a reduction in side effects because you're basically putting a bolus of drug into the pulmonary circuit. You don't see really systemic effects unless you have a really high dose of this drug and it kind of leaks out. From a drug delivery perspective, the drug is conveniently inserted into the diseased region. Okay, and then in terms of pharmacokinetic studies, we can really get a good tight control, and we can compare the 2 or 3 different brands to determine which ones are essentially biologically equivalent. All right, and so these are kind of unique properties of inhaled drugs from a pharmacokinetic standpoint, and that satisfies the either the last or the second to last learning objective. Okay. And so, of course, in terms of glucocorticoids, just to quickly kind of summarize, they have uses beyond asthma. So in terms of this curriculum, we're going to talk about glucocorticoids a lot. And so we'll come back to this slide, but this is just kind of a FYI. There's a really strong pharmacologic benefit to inhibiting the pro-inflammatory chemokines and cytokines because they produce or they exacerbate disease well outside of asthma. All right, so we'll stop here and we'll pick up in the next presentation.